For the second part of this week's lecture on Chapter 14, we're going to look at treatment efforts and social interventions in working with clients with emotional problems and mental health issues. The mental health movement, in fact, has developed out of the history of the treatment of mental health and interventions of mental health disorders, which has been very horrendous. Those of you who took my social welfare class may remember talking about Dorothea Dix, who's referred to here in this slide. She was an advocate for the insane, as I recall, is what they were called in the early 1800s. But the end result of her efforts was Congress establishing the 2 Million Acre Act, I believe it was called, which was intended to set aside land, the proceeds from which would be dedicated to the funding for mental health services for the insane. The president at the time, Franklin Pierce, vetoed that legislation, and it didn't actually take effect, but for political reasons about what he believed to be the role of federal government in dealing with needy clients, and that's the whole discussion in our social welfare class discussion that continues to go on to this very day, in fact, in our nation. But anyway, Dorothea Dix is one of the earliest American advocates for the rights of the mentally ill. Mentally ill individuals were thrown into institutions with criminals and all sorts of different kinds of characters in the early 1800s because they weren't producing, they weren't working, and they were living on the streets. Ultimately, their particular problems began to be differentiated some, but the institutions that were set up to treat those individuals continued to be pretty tough on them, and there were all sorts of interventions that were being used that, by today's standards, would be considered to be most inhumane. There were a lot of beliefs in those days that mentally ill clients were possessed by the devil. And so they were treated like that by the persons that were charged with their care. Physical and mental abuse was common. They were often put in restraints, straitjackets, chains, and those kinds of things. And really, they were given no sense of dignity or freedom. They were really not seen as human beings. Clifford Beers was actually, I believe, a mental health client of the system who wrote A Mind That Found Itself in 1910, and this was really about his struggle with mental illness, and it talked about his experiences with the mental health system in America at that time. And it was one of those publications that had a large impact upon how the mentally ill were seen in our society. The Connecticut Society for Mental Hygiene was an organization that he founded that eventually expanded into a national committee that was intended to improve our attitudes and understanding of the mentally ill, as well as to provide the services and for those individuals also. The National Mental Health Association was another organization, I think, that probably grew out of the Committee for Mental Hygiene and worked with the federal government really to result in the development and passage of the Mental Health Systems Act in 1980. President Kennedy had also given quite a bit of attention to the mental health field. His younger sister, Rosemary, long story behind that, but grew up in a mental institution, not necessarily because she was mentally ill, but because she had had a prefrontal lobotomy performed on her because of her acting out ways, and that was again one of those developing sciences in those days, and was seen as an appropriate intervention to actually go in and make surgical alterations to the brain. But what it did was it robbed her of her personality, and she lived out her days, and she lived well into her 80s, I believe, if not older than that, in an institution being cared for by individuals not in her family. And so the Kennedys had a particular, his sister, in fact, continued to champion causes for the mentally ill and developmentally disabled as a result of that. But in the 1980s, the Mental Health Systems Act was implemented and kind of tried to get us to shift away from the treatment of the mentally ill in institutions and to get them back into the community with their families and have what's known as wraparound services put in place rather than having them hospitalized. This is a term that was was the deinstitutionalization movement, deinstitutionalization of the mentally ill at that time. There has since been also a similar movement with the developmentally disabled as well, and so that you don't find a lot of facilities. You don't find many facilities or any facilities anymore for individuals that are not mentally ill, but who have other disabilities, and so those persons are cared for in the community and usually in their own homes now. The Americans with Disabilities Act was passed in 1990, and that protects mentally and physically disabled individuals from discrimination in areas such as housing and public accommodations, employment, transportation, and those kinds of things. Well, the deinstitutionalization movement was, and continues to be quite controversial because, well, let me tell you, first of all, there's a movie that you may have seen. And if you haven't, I strongly encourage you to do that. I think it won the Academy Award the year it was up in the 1970s, and it's called One Flew Over the Cuckoo's Nest. Jack Nicholson plays a character you'll never forget, and he is a relatively normal, but we would label antisocial kind of guy who winds up in a mental institution and. Well, I'm just going to say the rest of the story for you to see for yourself. But it's really a great movie and still very relevant today, although that particular type of institution that it characterizes doesn't much exist, I think, anymore. At least we want to tell ourselves it doesn't. Really, the only institutions for the mentally ill any longer, as this slide points out, I believe, is that the institutions that are there for the individuals who are a danger to themselves or others. The Alaska Psychiatric Institution being the really pretty much the only large-scale institution in the state of Alaska. And individuals with chronic disorders, nowadays, unless they're a danger to themselves or others, are put out in the communities and are managed by the mental health centers that were established with various acts in the 1960s and the 1980s. So this deinstitutionalization, the point of this was to get them out of those institutions, and the movie One Flew Over the Cuckoo's Nest kind of tells you what the institutions were like in those days. It's worth watching for that reason, and you can see there's good reason to deinstitutionalize those individuals. What the problem has been is that despite the fact that community mental health centers were established to look after those individuals, the services still aren't being adequately provided for those persons. For one reason, the individuals have a right to seek or not seek out those services. There are a lot of people out there with serious mental illnesses then that can opt to not obtain services, which leaves them really pretty gravely disabled out there in the community. And in fact, a certain portion of our homeless population, if not the largest portion of the population, whether they're drinking or not, a large portion of that population are mentally ill individuals who aren't being treated properly. And treatment can't be forced on those persons unless they're a danger to themselves or others. So they're no longer warehoused. They're kind of turned out onto the streets, but supposedly with services available in the community. But as the slide says, a lot of people felt they were being warehoused in urban and rural downtown areas where they're often left homeless and destitute. The idea is that by putting them into the community is that they'd be near their family and in their own home community and mainstreamed into society's existence with the supports and help that they need. In Alaska, in our communities, our mental health centers have, there's various descriptions and terms for the programs, but in Kenai it was referred to as the Community Outreach Program. I'm not sure that's the name of the program any longer, but the individuals that work in that program with the severely mentally ill involve, do provide case management services, get them out and get them into the community, mixing with individuals, helping them to shop, having them come over for socialization activities. But these individuals live in various levels of independence. Some of them live in housing that is somewhat loosely supervised. Some live in housing that is not supervised but have regular visitors from the mental health center, all those kinds of things. There's various levels of their involvement in the community and how they're living. I think the idea, though, was is that many of those individuals would go back to their families and have their families look after them as well. But as they grow older and their parents become older, it becomes less and less possible for the families to provide the things that these persons need, and so they really rely upon the mental health programs, I think, in large part to get along on a day-to-day basis. Here, this slide tells you that they think about a third of the homeless suffer from schizophrenia or manic depression, bipolar disorder, manic depressive disorder. There is a reference on one of these slides, it may not be this one, about, in this slide here where it says that commits about 1,000 homicides in the United States. And one thing I want to stress is that at least according to the last studies and research that I've been exposed to, that the mentally ill, the schizophrenic, are no more likely to commit violent crime than individuals in the general population. And that is a sort of a misunderstanding about schizophrenics, and when people are kind of fearful of them, part of the reason is because they're concerned that they could, the old term, they go psycho or whatever. I think we now call it going postal, but there's no more likelihood of violent behavior from a schizophrenic than there is from individuals percentage-wise than individuals in the general population. So that's something to keep in mind. But a lot of people think that while the intention of deinstitutionalization, which was to ensure that the chronically mentally ill were treated more humanely and were actually, involved and engaged in the world around them, what has happened in a lot of communities is a delay in treatment or a total absence of treatment and a worsening of the problem. Some of the mentally ill females have found themselves being raped. It says 22% of women with untreated schizophrenia, in fact, have been raped, about a quarter of them. And the suicide rates among this population are 10 to 15 times higher than the general population. About 500,000 of mentally ill people wind up in prisons. And again, it kind of calls back, I think, to the early 1800s when we had our almshouses and houses of correction, when our mentally ill were lumped together with criminals. And so there is a criticism about the deinstitutionalization movement because of the fact that we've kind of stepped back about 200 years for about 500,000 people at least. And the long-term kind of treatment and hospitalization that so many of the individuals suffering from these disorders require is really much harder to come by, because the vast majority of the funding for these facilities, these psychiatric facilities, have vanished since the mid-1950s, it says here, but certainly more so in the last 30 or 40 years. It says about 93% of the state psychiatric hospital beds have been eliminated. And so, not being hospitalized, then the alternative to inpatient treatment is outpatient treatment. And so not only do you have the case management services to help these individuals integrate into the community, but also therapy services may be very important to them as well. And outpatient mental health treatment, which probably involves both kinds of interventions, tends to have a fairly high dropout rate. Again, you can't force individuals into this, and so a lot depends upon the nature of the relationship between the treatment specialist, whether it's a therapist or a case manager or whatever it might be, and the client. And an important, I believe, important quality in any individual who is trained in to work with this population is that they also have a personality that can engage individuals and make people want to be with them. And so here you see the dropout rates. Well, by the 25th visit, 20%. Now some would say if you can't resolve your problem after 25 visits, no wonder people are leaving. But the truth is, we're talking about here, I think we're talking about chronic mental illness, and although a slide's going to dispute this a little later on, these are illnesses that just don't go away. You don't have talk therapy is not going to make this stuff go away either. So. And you see there's different reasons for clients dropping out that include, ineffective treatment and discomfort with the treatment process itself. There's a stigma associated with mental health services that causes people to avoid going to the clinics for treatment for help, as you can see. But people who don't think that the treatments are being effective, of course, are more likely to drop out. And so I think one of the things that this suggests to you, as this slide says, is that when you're working with clients, and mind you, social workers are, I think, the largest portion of professionals working in the mental health field, by the way, including community mental health centers. Social workers are the largest, they have the largest field, those degrees, let's say, that among those individuals working with these clients. And so one of the things that workers can do to kind of keep clients engaged is to help them in practical, realistic ways, like getting over, helping them maybe in job situations, job placement and perhaps support in vocational settings, helping them overcome barriers in a community that that cause problems for them, and doing those kinds of things in addition to the more traditional kinds of, so to speak, interventions, like whether it be therapy or it be medication management or whatever it might be. Having those practical kinds of supports and help in the community is something that's very, very important. And you see here there's a lot of criticism about treatment of severely depressed clients and psychotherapy, some debate about whether psychotherapy with or without antidepressants is more effective. There tends to be sort of this belief in the field, I think, that therapy with medication is the most successful combination for people with severe, and again, we're talking about severe depression here, but there's not a lot of support, this slide points out, in the literature, at least, to suggest that the combination of the two of them is more effective than using either approach alone. Depression, the popular belief about depression has been is that cognitive interventions are the things that are most effective in treating that. Now, there seems to be some dispute about that more recently, but that has been the common belief for many years. And so it would suggest that talk therapy for those that are not severely depressed could be very effective for those clients, but those that have major depression and can't get themselves out of bed or can't muster the energy because of that depression to take the steps they need to take to change things, sometimes medication is something that can be very helpful for them. But again, one or the other or both, it's debatable. Now here we talk about case management, and I've used this term a few different times. I had a case management class in my master's level training, and my instructor, who his name was Gerald O'Connor, was a strong believer in case management services, and he was a very traditional social worker. And I can remember him telling us early in the semester that people going into the social work field were reluctant to call themselves social workers anymore. It's almost as though it was an embarrassing thing, and they wanted to be counselors, or they wanted to be therapists or clinicians, intervention specialists, anything but social workers. And that this was a title, it was a field, it was a profession and a title that we should be proud to carry and to say for ourselves. And this is something that Dr. O'Connor left with me that 30 some years later still rings very true to me and is still in my mind. And he was my case management professor. He actually had written his own book about case management and systems theory, and this is something that I'm really quite sure you're going to have a lot more exposure to in the social work training at UAA and anywhere else you would take social work. It has become a widely accepted approach to treatment of mental illness and many other areas, and so less and less the mental health centers that were established to help the chronically mentally ill, less and less do they focus upon therapy interventions, and more do they focus upon case management services for that population, and also with severely emotionally disturbed children as well. And this approach really is well, you say here, I'll read you the definition. It's associated with case identification and outreach, assessment and service planning, service linkage, monitoring of service delivery, and advocacy. The case manager is sort of the go-to person for the client, and this is an individual if a case manager is going to be effective with clients, I would think that the case manager needs to be pretty stable, and by that I mean not moving through jobs. One of the problems with this field and the people in this field is that the work sometimes can, if it's not handled properly, can become overwhelming to the professional. You have to know how to take care of yourself, and I'm not only talking about self-care, but I'm also talking about being realistic in your expectations of yourself. If you go into this work expecting yourself to be able to perform miracles and to be able to solve all the client's problems, and that you're going to be available for them 24 hours a day, unless you're in a job that specifically requires you to do that, you should go home at night and take care of yourself and live your own life and go back to work the next day. It isn't anything demeaning about your clients, nor does it say that you aren't a good social worker. It says that you have a balance in your life. And when you have a social worker with a balance in his or her life, that social worker will stay on the job. And that's what client needs, consistency, someone who will stay there and be with them and will be available to them, and someone that they can spend enough time with to come to trust and to know and to rely upon that individual. And so a good case manager is going to be somebody who's going to stick around for a while, and if all those other people leave and move on to other jobs or leave the field altogether, that case manager is there connected to this client and helping the client kind of fend against all the things in the world and to get the services that client needs, and making sure those services are delivered in an effective and timely manner, and those kinds of things. And so case management has really become sort of the popular approach in terms of dealing with both child and adult clients in the mental health field. Now, a particularly effective type of intervention here that it talks about are self-help groups. And of course, the most famous self-help group is Alcoholics Anonymous, but there are a number of different self-help groups, and there's different kinds of self-help groups. AA prides itself on anonymity, and there isn't while there is a leader in the group, there's no professional therapist, so to speak, doing group. There are other groups where self-help groups that are called guided self-help groups, where there are professionals that sit in and facilitate things going on, but it's different from group therapy. So self-help groups, as you see here from this slide, tends to have some pretty effective, pretty impressive results. Patient-led support groups, for instance, that half as many former psychiatric inpatients required rehospitalization after 10 months of participation in one of those groups. 82% of members in a manic depressive and depressive association coped better with their illness after becoming members of a self-help group. 82% required hospitalizations before joining a support group, but the number fell to 33% after becoming members of the self-help group. And group members tend to experience a increased sense of security and self-esteem and an ability to accept problems in their lives without blaming others. One of the things about a self-help group is that you're not only receiving services, you're also giving it. You're engaged in a mutual support, and so it draws the client outside of himself or herself and allows the client to use some of their strengths to help others. And so you can imagine the self-esteem that develops in that. Now, self-help groups are available for different kinds of problems, not just alcoholism and drug abuse, and so if you're working with clients in the mental health field, one of the things, at least for adults, that you would encourage you to do is maybe look around to see if there's any good groups going that they might engage in. So, when you have a diagnosis, is this a lifetime condition? Is this something you're stuck with? And again, this is an area where there's a lot of discussion and debate about this, but the belief is that once you have this diagnosis, that you're going to suffer with this throughout your life. This is going to be a chronic, recurring kind of problem. But there's one study here by Carpenter that says that most people with a diagnosis of schizophrenia or some other serious mental illness experience either complete or significant remission of symptoms, and they manage to work, have relationships, and otherwise engage in a challenging and fulfilling life. And so this diagnosis does not have to be a doom diagnosis. It doesn't have to spell a lifetime of problems. It really has a lot to do with, well, in many cases at least, our expectations of our clients and how effective our interventions can be. Now, there may be some clients that won't improve, and again, we're not talking about 100% of the clients in any of these things. There are some clients who have a condition that just isn't going to change throughout their life, as we currently understand treatment approaches, at least, but most do improve, and many of them actually kind of move beyond the debilitating effects of schizophrenia and other major mental illnesses to be successful in their lives and to have a happy life. Carpenter thinks that the long-term impact of mental illness as an intractable disease is a widely accepted concept in the mental health field, and that this pessimistic view of mental illness continues to be communicated to people with psychiatric disabilities and to their families. You hear what that's saying? We communicate our pessimism about improvement and change to the client and the family. What do you think is going to happen in those circumstances? So it's important to remember we have to believe that change is possible, and to become optimistic about the possibility of that change. The consumer survivor recovery movement is something that Carpenter studied also, and this movement assumes that people with psychiatric disabilities can and will recover. And recovery defined here as a process of achieving self-management through increased responsibility for one's own recovery. This doesn't necessarily mean 100% remission of all symptoms. What it means is this individual has been able to grow and improve to the extent that they can manage themselves through their life, and to be successful in their recovery, take responsibility for their own recovery. So, hope provided by the person's professional, family, and peer support systems. Quite the opposite of what we were just talking about that pessimistic view. This is an optimistic view. And he says that these recovery triggers that helps people get over their mental illness comes from sharing this research of that improvement can change, that improvement can happen with the patients and their families and the communities around them that interact with them on a daily basis. If everybody expects improvement is much more likely to occur. Support groups here again is a part of this movement that is very effective in terms of decreasing recidivism, so to speak, and reduce rehospitalization rates and those kinds of things. These groups provide acceptance, empathy, and a feeling of belonging in a community, necessary information to help with management of social and emotional problems, and other very important kinds of things that enable the individual to function successfully. There are some organizations that respond to severe emotional problems and mental illness, and here's a list of some of them. I don't think this is exhaustive, but these are probably some of the major organizations. You have community mental health agencies, first of all. They tend to be provided with or funded through publicly funded services and government grants, but increasingly over the last 20 or 30 years we find insurance companies paying for these services, and government is pulling back from this. And this has a lot to do with the overall conservative trend in social services since the Reagan administration in the 1980s. Certainly some before that, but the mental health movement really had grown, and funding had increased in social work training. In fact, also there was a lot of increases in the 60s and the 70s. But by the time Ronald Reagan became president and wanted to reduce government interventions and instead of responsibly addressing social service programs and changing them in a way that might fit his model, what the federal government did was just turn over blocks of money. They were called block grants to states to take care of these problems however they will. And what happened in a lot of states is that services were not directed properly. The services actually funding was reduced, and clients have not fared as well ever since. And so what we find is a lot of the community mental health centers, in order to survive, have turned to insurance companies, which have taken on some of the private insurance companies, which have taken on some of the burden of that funding. But as you know about private insurance agencies, their goal is not to help people. Their goal is to maximize their own profits. And so that means restriction of services as well. And so Well, it's just an area for a good area for your investigation in the years ahead is how they continue to manage to function and what their funding streams are and what kind of services clients get as a result of all of that. Now, we do have one state mental hospital. There may be more than I think. Bartlett Hospital in Juneau actually also functions as a state facility. I don't know that there's any others in Fairbanks. I think Anchorage just has API, Alaska Psychiatric Institute. And again, for individuals who suffer from mental illness to the extent that they are a danger to themselves or others, the emphasis in those facilities mostly are to hold clients only as long as necessary to protect them, and there actually have to be hearings for them to stay longer than 72 hours, and judges make decisions about whether they're ready to be released into the community or not. Private practice professionals, social workers, psychiatrists, psychologists provide ongoing therapy and supportive care through their private agencies as well as through outpatient agencies like mental health facilities and other such organizations. Family service agencies provide low-cost social work assistance, and then, of course, self-help and consumer advocacy groups such as the NAMI is the National Alliance for the Mentally Ill, offer support and specific help to persons with these problems as well. And social workers really, as I mentioned earlier, I was told a long time ago that the largest percentage of professionals functioning in community mental health centers are social workers. And some have licensed clinical credentials, LCSWs, licensed degrees and things like that. Others are working on a bachelor's level in case management functions and other supportive roles. There's a number of different things that social workers do. And providing inpatient, outpatient counseling and psychotherapy. We tend to be a part of a treatment team, whether we're inpatient or outpatient, that involves a number of professions, other professions, psychiatry, social work, psychology, educational, and on and on and on. And so it is important to be able to respect the unique contributions of each of those professions. If you're in any kind of treatment team where a psychiatrist is on the team, probably the psychiatrist is, considers himself, at least he's a doctor, so he thinks he's in charge. And but that's not the case in all agencies. But there sometimes there is a bit of a hierarchy, but depending upon your organization. But nonetheless, social work contribution is critical. It's vital and very, very important in the successful treatment of clients with these particular kinds of problems. Aside from helping the clients on the kind of daily kinds of issues, like I said, they're also involved in writing psychosocial assessments and in exploring history with families so that we, the other individuals involved can also become more aware of what the contributions were, what the contributors were to that client's problems and the development of those particular issues in his or her life. So it's a good field to get involved in, and I will tell you that it's kind of like working with children. At some point or another, it's very likely that most of you will have some employment in a mental health field of one nature or another. Again, I just leave you with my little caveats about mental health diagnoses, and I'm not suggesting to you we can't dump diagnoses. Particularly if you're going to, if you're working for an agency that bills insurance companies, or you're going to have a private practice someday. If you don't diagnose, you don't get paid by insurance companies, and that's the truth, sad as it may be. And so it's we have to live with these diagnoses. We have to learn how to use them and use them effectively, but we have to be very careful not to let that change our basic belief about our clients and alter the way we see our clients. So again, stepping down off my soapbox, that will do it for this week, and I hope that you found these lectures informative. Let me know if there's any questions. Thank you.